Welcome to this explainer on autosomal dominant polycystic kidney disease, or as we'll be calling it, ADPKD. Today, we're taking a complex systemic condition and breaking it down into a clear, structured framework. As you probably know, ADPKD is the most common genetic cause of kidney failure worldwide. So our goal here is to really get into the weeds of the definition, the underlying mechanisms, and the cutting-edge management strategies that are actively changing patient outcomes right now. Here is our roadmap for today. We'll cover 5 key areas. First, definition and importance. Second, genetics and pathophysiology. Third, symptoms and complications. Fourth, disease diagnostic guidelines. And finally, disease treatment guidelines. Let's jump right into Section 1, definition and importance. Understanding the scope of the disease. So, what exactly are we dealing with? Well, ADPKD isn't just a kidney issue. It's actually a systemic, progressive, inherited disorder that gradually replaces healthy tissue with these clusters of fluid-filled cysts. Now, the kidneys are definitely the primary target, and they can become massively enlarged over decades. But it doesn't just stop at the renal capsule. This thing can involve the liver, the pancreas, the spleen, and even the cardiovascular system. Just to help you wrap your head around the massive scale of this disease, consider that it affects 500,000 individuals in the United States alone. Globally, we're looking at an estimated 12.5 million people across all races and demographics. When we talk about genetic kidney disorders, ADPKD is absolutely the undisputed heavyweight. It's literally responsible for up to 10% of all patients who eventually require dialysis or a kidney transplant. Now, a crucial point here is distinguishing this common adult-onset form from the much rarer and honestly more severe childhood recessive form. ADPKD is inherited as a dominant trait, with an incidence of about 1 in 400 to 1,000, and symptoms typically hide until adulthood. On the flip side, you have autosomal recessive polycystic kidney disease, or ARPKD. That one is remarkably rare, striking just 1 in 20,000 to 40,000 live births, with devastating perinatal or childhood onset. For our purposes today, we're keeping our focus firmly on the dominant adult-onset form. Moving on to Section 2, genetics and pathophysiology, let's look at the microscopic origins. When you break down the genetics, there is an overwhelming dominance of the PKD1 mutation. 85% of ADPKD cases stem from mutations in the PKD1 gene on chromosome 16, which codes for the protein polycystin 1. The other 15% are largely linked to the PKD2 gene on chromosome 4, coding for polycystin 2. And this matters clinically, because if a patient has the PKD1 mutation, they generally face a faster disease progression and reach end-stage kidney disease much earlier than those with PKD2. So how does a genetic error actually crush healthy nephrons? Well, it happens step by step. It starts with that mutation, which alters how those polycystin proteins function in the primary cilia of the renal cells. This dysfunction triggers a massive spike in intracellular cyclic AMP, or CAMP. Think of high CAMP as a dangerous growth signal. It stimulates massive chloride and fluid secretion into the tubules, essentially blowing them up like water balloons. This physical expansion causes localized ischemia and progressive, irreversible damage. It gets even wilder when you look at the cellular level. This continuous buildup of chloride-rich fluid relies heavily on those CAMP pathways and CFTR channels, driving independent cyst growth. And here's the truly fascinating, albeit terrifying part. Once a cyst reaches about 2 millimeters in size, it actually detaches entirely from its parent nephron. But because of these hyperactive cellular pathways, it just keeps autonomously secreting fluid and growing independently, acting almost like a benign tumor right inside the kidney. And every single one of those cysts originates from one genetically transformed cell experiencing what we call a critical second hit. You see, these patients are born with one mutated copy of the gene in all their cells, but it takes a secondary, localized somatic mutation, that second hit, in a specific renal epithelial cell to knock out the remaining normal copy of the gene. Once that happens, boom, that individual cell goes completely rogue, hyperproliferating to form a brand new cyst. Section 3. Symptoms and complications. What is the macroscopic impact on the patient? As we zoom out, there is a stark contrast between the localized kidney issues and the extensive extrarenal complications that make this a true multisystem disease. On the renal side, you're looking at chronic flank pain, blood in the urine, and painful kidney stones. But then look at the extrarenal side. We have to be highly vigilant for hepatic cysts, extremely dangerous intracranial aneurysms, and cardiovascular issues like mitral valve prolapse. Managing ADPKD absolutely means managing the whole patient, not just their kidneys. If there's one thing you need to watch out for, it's hypertension. High blood pressure is often the very first clinical presentation, appearing long before any actual decline in kidney function. It acts as our earliest warning siren. As those cysts expand, they physically squeeze the surrounding renal blood vessels. The kidney panics, thinks the body's blood pressure is dropping, and dumps renin into the system. This activates the renin-angiotensin-aldosterone system, driving up systemic blood pressure and putting the patient at serious cardiovascular risk, often while their routine kidney labs still look perfectly normal. Managing the extrarenal manifestations adds a whole other layer of complexity, particularly polycystic liver disease. Interestingly, because estrogen accelerates liver cyst growth, female patients, especially those who have been pregnant or used oral contraceptives, are at a significantly higher risk for massive, highly symptomatic liver enlargement. This usually requires specialized multidisciplinary care from hepatology. Without intervention, the reality of the prognosis is incredibly stark. Up to 75% of these patients will develop end-stage kidney disease by the age of 70. That relentless expansion of cysts and the subsequent renal fibrosis practically guarantees a progressive loss of functional nephrons. It inevitably drives the patient toward the need for life-sustaining dialysis or a kidney transplant, generally by their 6th or 7th decade of life. Section 4. Disease Diagnostic Guidelines. How do we accurately identify this threat? So here's the big question. How do we accurately detect ADPKD and, more importantly, predict which patients will progress the fastest? Because disease severity varies wildly, even within the exact same family. One sibling might never need dialysis, while another might need it in their early 40s. To personalize their care, we have to rely heavily on our imaging tools. For patients who already have a known family history, the Ravine ultrasound diagnostic criteria are brilliant in their simplicity. It all comes down to age and cyst count. If a 20-year-old comes in and has just 2 cysts, that's enough to confirm the diagnosis. But because normal, healthy kidneys can develop simple cysts simply as we age, a 65-year-old needs to show at least 4 cysts in each kidney to meet that same diagnostic threshold. But to definitively identify which patients are at high risk for rapid progression, we turn to the Mayo imaging classification. This relies on height-adjusted total kidney volume. By using an MRI or CT scan, we measure exactly how large the kidneys have become relative to the patient's age and height. Then we categorize them into classes 1A through 1E. The steeper the curve, so your classes 1C, 1D, and 1E, the more aggressive the disease is, meaning those patients urgently need disease-modifying therapies. And finally, Section 5, Disease Treatment Guidelines. Let's build our clinical action plan. Treatment builds up from foundational lifestyle tweaks all the way to advanced pharmacotherapy. We start by advising patients to drink a massive amount of water. We're talking about 3 liters daily. Why? Because high water intake naturally suppresses vasopressin, which in turn lowers that dangerous CMP we talked about earlier. We combine this with strict sodium restriction and really aggressive blood pressure control. Then, for those patients classified as high risk by the Mayo imaging criteria, we can bring in tolvaptan. This is a groundbreaking V2 receptor antagonist that directly blocks the vasopressin receptors, literally slowing down cyst growth at the cellular level. Of course, we also have to be ready to aggressively manage acute complications. Cyst infections are notoriously tricky because not all antibiotics can pierce that thick wall of a kidney cyst. We have to rely on lipid-soluble options like fluoroquinolones. For kidney stones, which are incredibly common and usually made of uric acid in these patients, we treat proactively with potassium citrate to alkalinize the urine. And for acute flank pain caused by cyst hemorrhage, we generally lean on conservative management, bed rest, and targeted analgesics. The overarching theme here, which is heavily emphasized in the 2025 KDIGO guidelines, is that managing ADPKD is absolutely a team sport. It requires nephrologist, cardiologist, hepatologist, and dietitians all working in lockstep. Adhering to these guidelines ensures we are actively fighting the progression of the disease with targeted therapies right from the start, rather than just passively waiting for renal failure to happen. So, as disease-modifying therapies like tolvaptan continue to reshape our entire approach, How will proactive genetic screening completely redefine the future for families carrying the ADPKD trait? I'll leave you with that thought to ponder as we continue to push the boundaries of patient care. We've mapped the genetics, we can visualize the pathology, and we are finally deploying drugs that actually change the natural course of this disease. The future for these patients is brighter and more proactive than ever before. Thank you for joining me for this explainer. Keep learning, and I'll catch you next time.